So thank you very much for being here today. We're going to discuss a penetrating trauma case that we got in our institution. Unfortunately, I was not directly involved in this patient care, but I tried to get as much as information as possible from the colleagues that actually did get this patient in the trauma bay and manage him throughout his time in the hospital. So I'm going to start the presentation. If you guys are you able to see the presentation normally and hear me well?
Yes, Carlos.
Yes.
Okay, thanks. So this is a 30-year-old male. He was a victim of a thoracic and an abdominal stab wound, and he came to the hospital eviscerated from this abdominal stab wound. The doctors that took care of him on the scene, they told us that there was a significant amount of blood on the scene actually, coming from these wounds, but he was actually quite stable. He had a heart rate of 80, an SBP of 140, and a Glasgow Coma scale of 14. He lost on the opening of the eye. He got 500 cc's of crystalloids and 1 gram of TXA during the hospital transportation. So upon the initial assessment, he had a clear airways. His breath sounds were decreased on the right side, and he underwent an EFAST exam, which showed a right pneumothorax. His right heart rate was 86, pulses were full, readily palpable. His BP was 135/70, and that was his circulation criteria. So he's still Glasgow 14, and on the exploration of on the inspection of the wounds, he had a thoracic stab wound right to the lateral side of the right nipple, and he also had an abdominal stab wound right on the right aspect of the umbilicus. So this was the presentation, and as I told you, he had an evisceration. He was transported using this plastic cover from the scene. So you may see that to the left you have the legs, and to the right you have the head of the patient. So this is on the right lower quadrant. So he had an evisceration with that you could see the viscera, not a perforated. This is a mistake from my writing. So it was an eviscerated colon, and he had diffuse abdominal pain, especially in the epigastrium area. And his labs on the trauma bay, his gas labs were BD of 3.7 and a lactate of 23. So I think that I'm going to skip the part where we try to decide what to do, but because we know that this guy is ending up on the operating room for sure.
Is that your real operating room? Because it looks beautiful. Is that your real operating room? It looks awesome.
Dr. Varun, I wish, I really wish that was our real operating room, but it's not. It's really different from this. So what I wanted to start the discussion with you, and that's awesome that Dr. Varun is here, because he will provide special comments on every aspect of this. So, and this is the first interesting thing that I wanted to discuss, because I always like to bring cases that I'm really not sure if we did the best we could. So I'm always trying to find anything that we did that was not adequate enough, or maybe things that we should do different. So this patient was intubated, and they say that he started to get a little agitated in the trauma bay, and they intubated the patient to transport him to the OR. So I wanted to ask you, the panelists, and everyone that want to join the discussion. So there are two questions here, but the first one, I would like to ask about, would you say that we should start looking for principles of CAB versus ABC applying to this case, because this is a very interesting and interesting discussion in the literature, and there are more and more studies coming talking about the CAB versus the ABC sequence. So I wanted to ask you about this case, this specific case, and which criteria would you use to try to figure out how to get this patient to the best management possible. And also, I wanted to ask you if in your institutions, are you trying to go to the CAB side versus ABC or not? So do you want to start, Dr. Varun, with comments?
I'll be happy to. First, I don't think we're going to switch to CAB in general. If you look at the new edition of ATLS, which is coming up, because I've been able to listen to the presentations, they're going to change the A, B, C, D, E. They're going to put a little X before the ABC, and that X stands for stopping the bleed. So if somebody's bleeding, that will have priority, stopping the bleed. But in general, if you see exsanguination hemorrhage, well, I mean, that's what you need to do before the airway. Obviously, if that's not the case, then the airway should take priority. But there's going to be a little X before that. So you're going to have airway breathing circulation, disability, okay, environment, and they're going to add an F, which is factors. And those factors are going to be consideration for OB, geriatrics, and peds, special consideration. So that ATLS is going to modify, and it's moving that way. Well, my gestalt in this is it really depends on how close you're to the OR and the status of the patient. I believe that if the patient is unconscious, you should secure their airway. Now, if the patient has penetrating trauma, and the patient, it's a Glasgow 14, so it depends on what we're talking about agitation. Sometimes these patients don't know what they're there, they don't know what the hell is going on. And if a little explanation and reassuring does it, then that's it. The patient should be intubated in the OR, because as you know, in penetrating trauma, in the moment you start positive mechanical ventilation, that blood pressure is going to drop. So it really depends on the level of the agitation. Now, if you're in the bay and you can't examine the patient because the patient is punching everybody, thinking that's the person that stabbed them, then yes, you have to take the patient down just so you can examine and do the procedures that you need. So it's not a yes or no answer. It's going to depend on your setting and depending on the patient's actual mental status, if it can be reassured or not. But ideally, in penetrating trauma, outcome depends on time from showing up to the OR, basically. So we try to expedite. When we have penetrating, we look for less than 5 minutes. Just the only thing you need is a type and cross, really, and a hospital number. Without those, you're in trouble. Hospital number and that. So again, depends on the level of the agitation. If you end up intubating the patient, then you would need to use low volume ventilation until we can stop the the bleeding.
Yeah, and what would you say that is a good strategy? I mean, can we use anything different from like heavy sedation in these patients who are really agitated? Would you recommend anything? I mean,
I highly recommend not to sedate the patient. And the reason is this: you would need heavy sedation. And we know this patient's travel through the hospital. You're going to be in places that you meant, if you end up going to CT scan, which I'm not saying this patient needs to go to CT because the abdomen is, patient eviscerated is going to go to the OR. Those are dangerous places where you don't have expertise to secure the airway. So you have to count on that. Now, when you do mild sedation, this is what happens. You disinhibit the patient. You give somebody 2 or 3 minutes of Versed only. Some of these patients, it's worse because now they're not listening to commands. So I would, if somebody needs to have sedation, they should have their airway secure in that point. If you cannot reassure him verbally or not enough with pain medication, if that's not enough, I think the airway should be secure. But I think frequently what happens, again, this patient show up, they don't know what's going on. They just need they see a bunch of people around them screaming at all these things. And I think a little bit of reassurance can go a long way.
Yeah, for sure. What do you say about using ketamine in these cases?
I would use it to secure the airway. I think in penetrating trauma, I think ketamine is the ideal choice to do that, to secure the airway. But I would still secure the airway in those circumstances. But I would use ketamine, 2 milligrams per kilogram IV. Or sometimes what we have to do is the patient doesn't have an IV, then we'll have to be IM and secure the airway with IM ketamine. I think ketamine is ideal for penetrating trauma.
Great, great, thank you. Dr. Kassim, would you agree? Do you want to add anything on what we're discussing?
Well, not all trauma patients present in the same manner to follow the algorithm. Also, the encounter of the patient in the trauma bay also is variant. You know, you have uh, doctors who are very highly experienced and also highly educated, and they know exactly what to do before you, as a trauma surgeon, arrives on the scene. And then there are others who fumble. You know, that is the nature of life. And like Dr. Warren pointed out, it is always crowded because there are looky-look people. They just want to look what's going on. They're curious. So you have to take into consideration what this patient looks like when he arrives at the trauma bay, and what are the important things that you should be doing to get the patient safely into the operating room. A patient of this nature, we're talking about the patient that you just showed a picture, does not need to go to the trauma bay. He should be straight away shipped off to the operating room as quickly as possible, where you can get all the other procedures done. And like Dr. Warren says, I rely on ketamine in an agitated patient more than Versed or any other medication. Once I give a small dose of ketamine, the patient calms down, and I have the luxury of continuing with my invasive procedure or even intubation if I wanted to. Ketamine can keep the patient awake, kind of awake and ventilating on its own, if you give the judicial amount of ketamine. And if you exceed that, then you obviously have to secure the airway. But when a patient like this arrives, don't take him to the trauma bay. Ship him off to the OR, where you can get everything done safely, securely, without a bunch of people looking to see what you're going to do to a patient like that. Thank you.
I just want to follow up on Dr. Kassim's comments.
Sure.
I just want to make sure people understand, when we take directly to the OR, they cannot come from the lobby directly to the OR. We have done that in the past and they all die. Without a hospital number and a type and cross, things are not going to go well. So I'm not saying spend an hour in the trauma bay, but or wherever you are, you just get the very basic type and cross and a hospital number. In our system, for example, we no longer have paper. There's no way I can get anything done in the OR, any record, anything, without a hospital number. Maybe we had all paper, maybe we will be able to do that. But nowadays, it's very difficult without those basic things. I'm not talking about labs. I'm not talking extra. I'm talking just the very basics, so the patient can go straight to the OR, either from the ER or from the trauma bay. But the OR cannot be the first stop. We have had a couple of patients that Miami drop off. You know, they dropped them in the lobby, and we thought it was a good idea to bring them straight into the OR, and things didn't go well.
Interesting. Yeah, I remember we discussed this sometimes here in the meeting with you, and these comments are really interesting. So I see that Dr. Untracht and Dr. Hochman are have their hands raised. I think Dr. Untracht has not just lowered his hand. I'm sorry I didn't see you before, because I have only limited view of the participants here. But Dr. Hochman, do you wanna add something?
Dr. Untrach raised his hand before me, so.
Okay. Dr. Untracht, are you there?
Whomever, you can go first, Dr. Hochman. Go ahead. I'll go after you.
Okay. A little bit just a follow up what Dr. Barron was saying. We have a system here for transporting patients straight from the helipad to the operating room. And when that system is activated, yes, as Dr. Barone said, you need to have a medical record to transfuse blood or to do any studies, even x-rays. If you don't have a medical record, that's not being done. So when we activate this protocol, the admitting office will generate a medical record with a fake name and a medical record number, and those labels will be printed automatically in the operating room. So by the time the patient arrives to the operating room, they will have all the records, and we can transfuse blood and do x-rays if we need to. We don't do it from the lobby. In the lobby, yes, the patient get registered, even if it's for like 2 seconds in the trauma bay to get registered and get our bearings about what's going on. Those patients go to the emergency department first, because the ambulance base is in the emergency department, and the lobby is in the emergency department. So they go there, and from there they go quickly to the operating room.
What about the type and cross, Dr. Kasim? Or you just assume they're just going to get O throughout the...
They get, we activate the massive transfusion protocol for those patients. So initially they receive and cross-match blood while the blood samples are being drawn and sent to the blood bank.
So you draw the samples in the OR, that's what you tell me?
Yes.
Got it.
Yes, but this is only for patients coming from the helipad, because all the others will go to the ED, as you mentioned. Really, we cannot bring patients straight from the street into the operating room. But for those patients that we know they're coming, because we get notification by the helicopter, we have a few cases where the ambulance, because there is some advanced life support that is run by the same company that runs the helicopters, the MedFlight. They want to do that, but those patients, we ask them, usually it's not such a severe case, and they usually go to the emergency room because there is no way to register that patient. We can potentially activate the helipad to the OR protocol, but we haven't done it.
Thank you, Dr. Hoffman.
Thank you. Dr. Untrak, do you want to add something? You were...
Yeah, certainly. So just to answer your questions, I think it was Dr. Ferrata that's been the big proponent of the CAB, and the articles that she published and the talk she gives. It's mainly the issue about CAB is if you're dealing with a hypotensive patient in shock, and then if you go to intubate the patient, you do a drug-assisted intubation, you'll precipitate cardiac arrest. So in a patient that's like this one, is normotensive, not tachycardic, that really is a moot point, because the rationale for the CAB doesn't apply. Also here, there's no need to sweep the patient up directly to the OR if he's not in hypotensive shock. He's normotensive, and you did the fast. I assume you didn't see blood in Morrison's pouch or elsewhere in the abdomen, and it looks like he's just got 2 stab wounds. So, the answer to your first question, in this case, look, I would say it's either, but it's kind of a trivial either, because CAB, the circulation's okay, and then so that's done and immediately, and then it's airway breathing, and then certainly I would put a chest tube right in the ER, wherever the first place he arrives, before you do a laparotomy, just to be sure he's not bleeding. And if there's no blood coming out, if you just poked his lung and got a pneumothorax and perforated the abdominal wall, and he eviscerated a loop of bowel, that's not, that's we would call that a yellow case, not a red case, but a yellow case. I mean, we get patients like this when I was in Africa that, they'd fall out of a tree in the morning and they wouldn't arrive to us. They're 100 miles away. They go in a car on bumpy roads. They get there 12 hours later, just as good as the minute they were picked up off the forest floor, because they're totally stable. Because that's just the nature of the wound. So in this case, I think I agree that intubate. And I think what Dr. Verone's point about the ketamine, I think that's probably the best anesthetic to use, and probably because it won't make the patient get hypotensive. If I understand correctly, Dr. Verone, is that right?
That is correct. Less likely, however, if the patient is catecholamine charged, any agent, ketamine, etomidate, will drop the blood pressure if the patient is at that point. I truly believe that the dosing is sometimes much more important than the drug, because any drug can give you cardiovascular collapse. So you just have to be very careful with the dosage. It needs to be adjusted if somebody's in shock.
And the other point is about the airway. They're talking about, okay, you can intubate the patient and, you can do a drug rapid sequence, whatever. But a lot of these trauma patients, when they come in, they can be very difficult intubations. And my feeling is if your back is against the wall, you have somebody that you need to open the chest or whatever, they're really hypotensive and they have no airway. So I would just, have them be given ketamine and do a cricothyroidotomy, have the ER doc do that, and then you do whatever else you need to, whether it's open the chest or put a reboa, whatever. But I just think that's the more expeditious approach if you're really worried about precipitating cardiac arrest.
Yeah, awesome. So really enjoyed this discussion because it's very. I mean, I agree with the concept, and it does not really apply to this patient. I just wanted to raise this discussion, and I think that it was really interesting to have all of your inputs in this matter. So in the interest of time, I will just go over the next slides, and I'm really also thankful for having a lot of you guys as panelists here, because we can enhance the discussion of this case. So what this patient went through, he on the way to the operating room, he started to have worse hemodynamics. The team elected to do a finger thoracostomy, which ended up having air leak only. The fast exam did not show any hemothorax as well, only pneumothorax. And this patient was starting the transfusions. So he went in this scenario for a laparotomy, and what they found in the laparotomy was through and through 2 centimeter column injury right in the hepatic flexure. And there was a mesenteric tear with active bleeding. What they told me is that it was oozing, but it was not like a very big hemorrhage. And there was a zone 2 right retroperitoneal hematoma that they saw during the surgery. And this was the timing. So from arrival to OR, it took 50 minutes to get this patient to the OR. And I wanted to follow up the discussion asking you about what would be the strategies in this situation. I have some pictures that I want to show you guys in a bit, but I wanted to ask the surgeons, how would you approach this? What strategies and maybe what are the main tips and advices that you could give for how would you approach this patient, especially regarding the right retroperitoneal hematoma? So I think I'll call for Dr. Gustavo Fraga, which is a colleague of mine from Brazil as well, to make these comments. Dr. Gustavo, are you there?
Yes, thank you, Carlos. But no comments because I started the meeting delayed, so I don't know the first the scenario about the patient. So I just listen. Thanks so much.
Okay, no problem. Okay, no problem. So Dr. Kassim, do you want to make any comments in this initial approach?
So you do a laparotomy, and the first thing you need to do is stop the bleed. That's what I would do. Stop the bleed first and assess the situation, and don't rush. Once you stop the bleed, you allow the anesthesiologist to catch up and see the land, the scenario at that time, to see how the patient is responding, and if he is getting stable, things are looking good, and then go ahead and do whatever you want to do with that colonic injury. In my hands, I probably will resect and do a primary anastomosis. And at the same time, I'll have my left eye on that retroperitoneal hematoma to see if it is expanding If it is expanding, then I have to make a decision whether I want to go after it. If it is not expanding, by the time I finish with my anastomosis and it remains stable, I think I will probably quit and get out. Thank you.
Very interesting. Very interesting. Dr. Untracht, would you agree with that?
Yes, although you say mesenteric tear, so is mesenteric the small bowel or to the colon, to the right colon?
I think it was the right colon.
Well, the right colon was a perforation, but that, if it's a stab wound, I would expect the small bowel to be in the way, so that matters. So if it's just in the mesentery, just be sure that in mesentery, the small bowel, be sure that it's that there's no devascularization of a segment of the small bowel. Likely there wouldn't be with this kind of just a stab wound. I expect just in and out stab, and then you just repair that, like Dr. Kasim said. And then if it's in the colon, there's several factors. It depends on the length of time from the injury to when you're in the OR. So it's 50 minutes plus how long after the injury till the patient got to the hospital. How long is that? Less than an hour?
So from when he arrived to the hospital until the OR was 50 minutes.
50 minutes, but what about before the arrival to the hospital? Is that less than an hour?
We don't have this information, but it probably
yeah. Go ahead.
Yeah, no, it's probably less than an hour. Most of the time they take 20 or 25 minutes to get there.
Oh, okay. So less than 2 hours, and it depends on how the field looks. If there's minimal, if there's minimal soilage, then you can just do a direct repair, primary repair, and that wouldn't necessarily require mobilization of the hepatic flexure if it's right in an area that you can see. And but in general, especially with the hematoma in the retroperitoneum, if you thought you needed to do a resection, and when I trained, it was just before all the talk about repair, and all of those would get a resection, a right colectomy, because you can do an anastomosis, ileocolic anastomosis. But if you think you need to do an anastomosis, like Dr. Kasim said, that would require mobilizing the right colon anyway, and then you would be in the retroperitoneum. You wouldn't be in Gerota's fascia, but you would be in the retroperitoneum looking at the hematoma, see if it's limited to the kidney or elsewhere. So, and generally for stab wound, that's a zone 2 hematoma. If it's due to penetrating trauma, in general, you would explore those. So, and certainly if it's expanding, but even if it's not expanding. So, depending on what you would do, you could do a primary repair, but taking into account the hematoma, even if you can do a primary repair, probably it's safer to just mobilize the right colon, look at it, see what the hematoma is doing, see how much soilage you have, and either do a primary repair or, like Dr. Kasim said, a resection with ileocolic anastomosis.
Great, very, very interesting. Thank you very much. Dr. Hochman, do you want to add something? Do you agree with the comments?
Yeah, I agree. I don't have too much to add. I think that everybody was just perfect. Thank you.
Great. Thank you. So I'm going to move on a little bit. And if you guys are not seeing the photos, please just tell me. So this was the retroperitoneal hematoma. They saw that this hematoma was mainly, remember that the stab wound was in the right lower quadrant. So this hematoma was very close to the iliac vessels, and that's what the team was worried about. So they didn't specify about the expansion of the hematoma, but they were really worried about having a vascular injury. And when they started dissecting this area, so you can see, I don't know if you can see my cursor, but over here to the left is the common iliac vessel. On the right, more to the upper side, it's the internal iliac, and the other one is the external iliac artery on the right side. And they started to dissect, and they found this hematoma, and what they saw was this puncture wound in the external iliac artery. It's very, very small. And the surgeon who was operating this case, he told me that there was no active bleeding from this small puncture wound. So they thought that it might have bled some time after the injury and was responsible for the hematoma maybe, but there was no bleeding on this at least when they dissect this structure. So he found no bleeding. So it's really small, and they told me it was approximately 2 to 3 millimeters of wound in the external iliac artery. So that was the finding regarding the vascular injury. And I wanted to ask you, the panelists, again, about what would you do next. So I know that Dr. Cassim didn't want to explore the hematoma, and I think he made a nice point on that. But assuming that we explored it, and how would you treat this? Would you do anything, or would you just leave there, or maybe another option that I didn't list there? So Dr. Untracht, can we start with you?
Certainly. So in this case, so that there was a hematoma there, so it did bleed. So they, it's through into the, must have been a small knife. It just made that, or maybe just the tip of the knife, maybe just nicked that. I would, in this case, went through, so it got stabbed once in the right lower quadrant, but then again at the hepatic flexure. So which stab wound you think it was the one by the upper stab wound was the one that nicked the coat? No, that couldn't be. That went into the pleural space. So it was the lower stab wound that nicked the hepatic flexure, and then he pulled it out partially and went in again through one stab wound. I guess a nice guy, rather than stab him head of skin twice.
Yeah, we so it was very, very confusing in this case, because he had only one stab wound to the abdomen. So I really started to, after I reviewed the case, I was wondering if it was really a hepatic flexure, because the stab wound is right on the right lower quadrant. So I think it's very possible and very probable that it could hit the artery, the iliac artery. So it seems that somehow this stab wound caught the colon, and the same stab wound would get the iliac artery. It's everything that we have on reports, actually.
Yeah. Well, so anyway, in this case, I don't see the need to venous graft or biological material. I don't see the need for, it's a small wound, and I would suture it, but I think probably I would, in this case, do a little transverse arteriotomy. Yeah, and primary, number 4, what you said there, and primary repair, and clean it out carefully. There was blood there, but I guess no stool there. Maybe they couldn't tell; it was too messy, whatever. But I would do in this case number 4. Mm-hmm. Right. Yeah, I wouldn't just leave it, even though it's not bleeding, because I think that's risky. You get a pseudoaneurysm or rupture later, whatever.
And would you recommend doing an incision on the artery and then closing, or just close it like the number 1?
No. Number 4, the arteriotomy followed by primary. I would do probably transverse arteriotomy, a small one. Just look at the edges. Be sure that you place the sutures. Through the intima and then out. Use double armed. Just to do a good repair, so there's no intimal flap and occlusion later in the external iliac. And it's easy because it's all exposed. It's right. They do it right the first time.
Perfect. Dr. Hochman, any additional comments?
I always say, if somebody did something stupid, I probably did it twice before. So I will make a very stupid comment. I will just prepare this primarily. It's very, very small. It's 1 stitch with the number 4-O-proline or 5-O-proline, and that's it. If it's any intimal disruption, I will get it with a stitch and just get it over. I wouldn't make this more complicated. So that would be me, and probably is wrong. Thank you.
Excellent. Thank you. Dr. Kassim?
Well, if I found this during my right hemicolectomy, and I would do an arteriotomy because there might be one in the back of the artery. I don't want to forget that. I could repair the anterior hole, but what about if there's one in the back? It'll give me problem later on. So I probably will do an arteriotomy and have a look at it, and then I don't like to do primary repair because invariably it narrows in my hand, and I would probably put a patch graft, whether it is Gore-Tex or Venus or whatever it is. But in a case like this where there's no contamination, no stool everywhere, I probably will quickly put a patch graft and get out. And then I would also do a completion arteriotomy with a butterfly needle on top of it and put some dye in and have a look to make sure that I didn't mess up anything. Thank you.
Great. Thank you very much. Yeah, that's very nice suggestions. So what the team did was a primary repair with no arteriotomy. They did a suture with a 5-0 Prolene. And so that was it, and they left the case after that. So this was the surgical report. So a primary repair of the colon injuries, both the anterior and the posterior aspect, suturing of the mesenteric injury, and suturing of the external iliac artery injury. And these are the scores: the ISS of 17 and a TRIS score of 98%. So this patient got on total 4 liters of crystalloid, 3 RBCs, 3 FFPs, and 2 grams of fibrinogen during the preoperative phase and the operative phase as well. He got a chest tube in the OR, and some colleagues in our hospital they like to use the OR X-ray to do the drainage, because they can maybe put this drain in a better position than if you would do without any type of imaging. So that was the idea. And again, there was no hemothorax, only a pneumothorax in this case. And these are the lab results from the preoperative phase until the postoperative phase. And we can see that he had a base deficit of minus 3.7 before the surgery, and then minus 1.6, and the lactate as well was decreasing. So he was fairly stable and with good hemodynamics as well in this scenario. So now we're going to the postoperative phase, and we are going to have an interesting discussion here as well. So he was admitted to the ICU, he was intubated, and during the first postoperative day, the team, while assessing this patient, they noted that the distal pulses on the of the right lower extremity were absent, but he had a good perfusion overall in the lower leg. So I wanted to ask you, what would you do in this scenario? I mean, what does this mean? And what about, would you investigate somehow? Would you do anything different? And I think that we're starting this discussion from here, and then we're going to move forward. So, Dr. Hochman, are you available to comment?
Yeah. One thing. Dr. Kassim mentioned that he will open to look for a posterior injury. I would assume that the artery was rotated before proceeding with the repair to rule out a posterior injury. So you have only an anterior injury. I will also repair transverse. It was, I don't know, the initial picture that you sent show us was very small, so probably just one stitch. That was a long suture line there, but again, it's difficult to say. So you have to suspect now that something went wrong there. One possibility is, yes, the injury didn't go all the way through the posterior wall, but caused an intimal tear in the posterior wall, and that led to a clot formation there. So the next step will be a CTA to see what you have and go from there. Thank you.
Perfect. Dr. Kassim, would you do anything different?
Well, this wouldn't have happened because I would have looked at the anterior as well as the posterior, and I would have done an intraoperative angiogram so that I can sleep well because I love to sleep. And but if I messed up something, then of course, I'm going to feel sorry for myself and take the patient for an angiogram to see what the hell did I do wrong here, and then return the patient back to the operating room. The one thing I would not do, I would not play ostrich. A lot of surgeons I have seen, they play ostrich. Oh, the perfusion looks good. Let's wait it out to see what can happen. I would not do that, and I would recommend young surgeons don't do that. Ostrich is a bird. No, it doesn't belong in the surgical armamentarium. Thank you.
That's a great advice. Thank you very much. Dr. Untracht, do you agree?
Well, yeah, the thing is, a little bit more information. So distal pulses are absent. So in other words, femoral and popliteal pulses are present, and then the no pedal pulses. Is that right?
Yeah, no pedal and no tibial, posterior tibial pulses.
Right. Okay, but the popliteal pulse is okay. So you have perfusion through the arterial repair. Then the issue is, what was it like before? And I missed how old the patient was. I assume he's young, but
Yeah,
so
he's
yeah,
30 years old.
okay. And then do you have ankle brachial indices?
Yeah, we don't have this information.
Oh, you didn't check afterwards, but they're well perfused. So and it's the patient is totally asymptomatic. The foot looks pink. It's not pale. It's not painful. It's not, and I think it's reasonable. And and it also, I don't know how well you didn't know that you're going to find this in the OR. Probably there wasn't a very careful vascular exam preoperatively, right? That probably what I'm sure they didn't say pedal dorsalis pedal posterior 2+. I wouldn't do that in a case like this. I wouldn't. So you don't have that information, and now maybe you don't want to first do no harm. You don't want to cause harm, and I think it's reasonable if you want to go ahead and do the like Dr. Hockman said, the CT angiogram non-invasively, look at the because that repair looked very good. I mean, and I'm sure they saw it. It was pulsatile in the OR, and they had a pulse distal to the repair in the OR. So this may be a little bit of a red herring, something that was maybe like that before, maybe some spasm, and I think at most, I would check the pressures, ankle brachial indices, both compare the two sides and watch the perfusion. If I really wanted to satisfy the malpractice lawyers, I would do the CTA, just to cover myself, whatever. But it sounds like from the information you presented, not something to be too excited about.
It's perfect. Yeah, so that's exactly what the team thought. I really don't have a lot of information preoperatively regarding the vascular evaluation, because I started to think that maybe they didn't thought that there was a vascular injury beforehand. So that's why we don't have a lot of information and detailed information on that. And someone on the chat, I think it was, I'm not sure, but I think it was Dr. Epstein. He asked about the O2 saturation in the toe, and also if anyone did a Doppler in the ICU, and they didn't. So I don't have this information either. So the idea was to do a CT angio of the lower extremities, as you suggested as well. I'm going to show you what we saw in the images. So just quickly stop here. And so this is the aorta and the vena cava. You will see that as soon as the aorta bifurcates, you'll see that there's the internal here and the external, it disappears, and then it's going to be the femoral is going to have the contrast again over there. So there's a segment in the external iliac artery that has a thrombus, and it's I mean it's very difficult to see, but it's over here. and the other artery went down. And what you see here is a femoral venous line. So that's why it's enhanced in the image. I'm going to show you also the coronal and the sagittal images. This is the sagittal image, and it's fairly nice to see this image as well. And you see that the artery, it disappears and then it reappears over here, down here. So that's what we thought that was going on. So this is the catheter again. This is the artery with the thrombus over here. So it's not the artery is not contrasted in this part anymore, and it disappears and then it reappears over here. So it's the same in the coronal view. So it seems that there's a thrombus in the external iliac artery, and we can see the left over here, and we can't see the right external iliac artery, but it reperfuses here in the femoral artery. So that's exactly what you thought it was. It's a big thrombus in the external carotid artery. And so what to do next? Would you have any ideas on what to do? Should we do anything endovascular? Should we reoperate this patient? And if reoperation, what would you do in this scenario? Dr. Untracht, do you want to start?
Certainly. So in this case, it sounds like from the repair, there was intimal flap, probably is what it's going to be, and reperfused through collaterals. So the leg is okay. In this case, I just asked the interventionalist to have a look, and if there's a thrombus, they can remove it and then put a stent. If it looks like it's just an intimal flap with thrombus in the stent, they can probably place an uncovered stent that would maintain perfusion to the internal iliac on that side and reestablish flow, unblock the external iliac. That would be my preference. Failing that, you could take them back, or you can do an extra anatomic repair. But in a young person, I would try to. That would be the last resort, femoral bypass. But you shouldn't have to do that in this case.
Great. Dr. Hoffman, do you agree?
This is one of the cases where I will consult vascular surgery. Let me ask you a question. Was this patient anticoagulated during the case, or did he receive local heparinization there in that area? Because the area that had the clot is more or less correspond to the areas where you had the vessel loops.
Yeah, so he did not get anticoagulation intraoperatively, but he had he got the prophylactic dose of heparin postoperatively.
Yeah, this could be a clot that formed at the time of the surgery from the arterial occlusion. Maybe there is nothing there, but I would probably call the vascular surgeons. My feeling is that you need to explore this, make sure there is not an intimal tear that is so big that is causing this to clot. So that's what I can do this time. This is not something I will do myself.
Mm-hmm. Perfect. Dr. Kassim, any comments?
I would acknowledge that this is my mistake from the first surgery. I would take the patient back to the operating room. I would not deploy the interventional radiologist because this man is only 30 years old. Putting a stent would not be the ideal situation in a case like this. And I would like to correct my mistake, whereby I would take the patient back to the operating room, look at it, open it up, and solve my problem with the interposition graft, and then go home.
Nice. Very interesting, because that's the beauty of this meeting, of different opinions and different approaches. So that's what the team did. They called the vascular surgeons, and they evaluated the patient, and they thought that the best idea would to take back this patient to the OR to have this fixed. But the patient didn't want to be operated on. He told the team that he was fine and he didn't have any pain, and that was fine. And after a lot of discussion between the team and the patient, the patient actually refused any forms of treatment during this approach. What happened is that almost a week after the surgery, the patient started to have a claudication and paresthesia between the third and the fifth right toe. So the patient started to feel symptomatic from this occlusion. And so the vascular team rediscussed this case several times. And when the patient started to feel symptomatic, he finally agreed with the proposal of the vascular surgery team to be reoperated. And what they did, and I spoke to the vascular surgeons who were on this case, and what they did was they performed an extraperitoneal access on the right groin. They thought that it would be bad to go using the laparotomy again because of the adhesions, and they weren't safe to go this route. They told me that this dissection was very, very difficult, and they had a lot of bleeding coming from the external iliac artery during the dissection and from the common iliac artery. So because of that, they decided to go a little upstream, and they started to dissect the arteries until they reached the aorta, where they did a longitudinal incision in the aorta and a longitudinal incision on the common iliac artery as well. And what they did, they put a saphenous graft between these two areas. So this was this is the anastomosis that they performed, and so they finished the case doing this bypass. So they didn't use any prosthesis, just the saphenous vein as a graft. So the patient, after that, he was demonstrating present distal pulses, good perfusion. He got result from this paresthesia and the claudication. He was discharged home after the second day from the vascular approach, the vascular operation. And on the last, he did only one follow-up consult with the team, which was like 2 weeks after the discharge. And this patient, he was lost to follow up, and we did not see him again. And this has been maybe 5 or 6 months now. So he got lost to follow up, and we did not have any information on this patient anymore. So that was the case that I wanted to discuss, and I think that was really interesting to hear your thoughts on these and these approaches, on these options that we have when dealing with vascular injuries. And I really think that maybe this kind of tips and this kind of things that you have to do in repairing the vascular injuries, they are really fundamental. And sometimes we do not follow these specifics in these cases, and maybe we can get in trouble because of that and have to sometimes do another intervention. So I want to go another round with the panelists to make sure we are having all the final comments on the case. So Dr. Hochman, any final comments, any tips, any advices?
No, just I don't know if the patient after the surgery was anticoagulated, because assuming that he had the clot there, one of the options is to keep the patient fully anticoagulated and prevent propagation of that clot. But otherwise, really, no. I would have done almost exactly what you guys did there, so I have really not too much to add. Thank you.
Yeah, nice. Dr. Untracht.
Yeah, just a little curious why the vascular surgeons, they're the experts, but what was their rationale for not doing an interventional procedure to put a stent and reopen the vessel, avoid all the difficult reoperation?
Yeah, so that's something that I didn't quite understand from them, but what the vascular surgeon told me, it was that they just discussed the options, and they thought that the best idea would be to like approach it surgically, but they didn't give any specific details on why not trying to do this percutaneously maybe, but that's what they did.
Yeah, and I guess the take home is, do a little arteriotomy so you can be sure of your closure, and that you're not creating intimal flap that can occlude. But there you go.
Yeah, exactly. And the vascular team also made this point to the trauma surgical team about maybe doing the arteriotomy would be better to better understand what's going on, and maybe the cause of this thrombus could be not heparinizing the patient adequately intraoperatively, or maybe the intimal tear that was not seen. Dr. Yoshiro, he put on the chat, after hearing the complication of primary repair, how many of you would dare to choose the primary repair for this small injury? Very, very interesting idea. And Dr. Yoshiro, if you want to open your mic to comment on that, and on what would you do instead of a primary repair, it would be really, really nice if you were able to do that.
I would choose primary repair after hearing this complication. But so I hear this complication very bad complication. So I imagine if he had arteriotomy, some doctor said would cause no complications after the first operation. So I would like to ask all of you.
Yeah, I think that might be a lesson learned, right? So I don't know what they thought on that moment, what was the idea, but for sure we thought that maybe the stitches they may have left an intimal tear that was maybe posteriorly, or the stitches when they did without the arteriotomy, probably the suture was not adequate. So we actually don't understand exactly what happened, but this is a very plausible explanation. So I think that, at least in my point of view, I wouldn't stop doing the primary repair, but I would sure remember to do the arteriotomy and make sure I'm looking and I'm evaluating the injury on its whole before trying to put the stitches there. I think that's, at least for me, it would be a nice take-home message. Dr. Kassim, wanna comment on that as well?
I would like to comment on the deployment of the long saphenous vein as the conduit. Remembering this is a 30-year-old man, and he has another 32 years of life expectancy, and those vein grafts don't last that long, in my experience. I've been doing vascular surgery for 30 years, and I'm always very leery using saphenous vein as a conduit for younger patients. If you don't have a contaminated wound, and in a large caliper vessel like this, I think I prefer to use a Gore-Tex graft, which has been shown not to allow infection to occur as readily as other grafts like Dacron, and also the longevity of the Gore-Tex has been proven to be sustainable. But otherwise, I would have done exactly the same thing, but I would have probably inserted a Gore-Tex in this case and saved the day. Thank you.
Very
Good
interesting.
case, and several things to learn here. The number one is, when you have a hole in the anterior, make sure that the posterior is okay before you close it.
Perfect. Awesome. Well, thank you very much for all your comments. Thank you, Dr. Kassim, Dr. Untracht, Dr. Hochman, and Dr. Varon. He had to leave early, but his comments were really interesting in the beginning of the case. I hope to bring other cases for discussion in the future, and I really appreciate all the comments and everything that I learned every time I present cases here from you guys. Thank you very much, and see you next Monday.
Thank you.
Thank you.